So coronary artery disease EKG changing, right? So first of all, I want to share with you what are the normal EKG. So if you have a look on this picture, you can see this is the P wave. P wave is the activation of atria. And then QRS complex, QRS complex because of activation of ventricle, and TUF. TUF at the recovery phase, right? So another way I want to tell you, the P wave is a positive deflection. QRS complex is a positive deflection, and ST segment should be horizontal. You see, horizontal, this one. And TUF positive deflection. This is the normal. If you know the normal, then you can find out what is abnormal. So what graphical change occurred in EKG in case of coronary artery disease? If we see the EKG of coronary artery disease, we can see ST segment depressed. So I said ST segment should be normal, means horizontal. But if it is depressed or negative, this is called ST segment depression. So ST segment when negative or not horizontal, it is abnormal. So TUF, it is here, you can see this is called TUF supposed to be upright steer or positive deflection. But if it is not look like this, if it is just opposite direction, like here, this is the TUF. But in the picture number 3, TUF is negatively deflect, I mean downwards. This is the inversion T, right? Suppose my head is up direction, but if my foot towards the roof and my head on the floor, it is inverted me, right? Inversion TUF. And also abnormal QF we can see. In this picture showing the normal EKG, second picture ST segment is depressed, and when ST segment is depressed, it means some ischemic change occur. But picture number 3, ST segment is up direction, but it's supposed to be horizontal. This is also abnormal because of injuries, right? So this is the graphical abnormalities we found in EKG or ECG in case of coronary artery disease. Another diagnostic study for coronary artery disease are cardiac catheterization. What is cardiac catheterization? Cardiac catheterization provides the most definitive source for diagnosis. Also, cardiac catheterization can show the percentage of blockage of the artery or presence of atherosclerotic lesion or lesion. Here in this picture showing like this one, showing the narrowing the artery in X-ray image. Then we have to passing the catheter, and catheter by femoral artery go through the abdominal aorta, thoracic aorta, arch of aorta, and finally come in coronary artery, and then balloon up and narrow area is expanded. In other picture, we will see. Cardiac catheterization provide most definitive source of diagnosis. Also, cardiac catheterization show presence of atherosclerotic lesion. What next? Next is here the blood lipid level may be elevated. Cholesterol lowering medication may be prescribed. So there are some type of lipid, right? Some type of lipid I said. So like LDL, LDL, and also HDL. So LDL is a bad cholesterol. The low density lipoprotein, they are bad. Why they are bad? Because they carry the bad cholesterol from periphery to the heart and causes atherosclerosis. The patient who have the ischemic heart disease, usually the LDL is more than the upper limit. On the other hand, the good cholesterol, which is called the HDL, means high density lipoprotein, they're good. Why? Because they carry out the bad cholesterol from heart to the peripheral organ, and they act as a scavenger. They protect your heart. The patient who have ischemic heart disease or coronary heart disease, usually low density lipoprotein go up and high density or HDL go down, right? In that cases, the patient basically need cholesterol lowering medication. Basically, most common cholesterol lowering medication is called statin, simvastatin, right? And a common question sometimes NCLEX board asks, what time usually give the cholesterol lowering medication? During evening time. Why evening? Because cholesterol deposit during the night time, right? And cholesterol lowering medication like statin reduce the development of atherosclerotic plaque formation. What else? Intervention as a RN or LPN, what are our responsibilities? So it is important for our board exam. Like you has to assist the client to identify the risk factor. What are the risk factors? Like positive family history, obesity, smoking, alcohol, male gender, or menopause women, right? So some of the factor is possible to modify, but some are not. Sex is not possible to modify, but you can change your lifestyle, you can do your physical exercise, and you can protect the coronary heart disease. So also reinforce the instruction to the client regarding low calorie, low sodium, low cholesterol, and low fat diet. So low calorie, low sodium. In case of kidney disease, low sodium, low protein, and food restriction. In case of heart disease, low sodium, food restriction. Stress to the client that dietary change are not temporary, must be maintained for lifelong. Also give them some community resources so that they can get more information for the life. So when we need the surgical management for the patient, so what we do, basically angioplasty, or we can do the angiogram, coronary angiogram, we say it. That is the diagnostic procedure. So invasive procedure used to determine if the patient has coronary artery blockage or narrowing. So pre-procedure or post-procedure education is very important for the patient. And also we have to go for angioplasty, but coronary angiogram determined your patient need plasty or arteriectomy or PCTA. PCTA means percutaneous transluminal coronary angioplasty. Some books said PCI. PCI stands for percutaneous coronary intervention. So PTCA to compress the plug against the wall of the artery and dilate the vessel. Arteriectomy means something is cut, remove, reconstruct the arteries, right? Sometimes we use the stent. It's called vascular stent. So stent push inside the narrowing artery, balloon up, and then remove the divides, and stent should be there. And another one we use is called coronary artery bypass grafting, right? Coronary artery bypass. So coronary artery bypass grafting, it is the surgery to bypass one or more coronary artery due to the blockage and or persistent ischemia. Usually, saphenous vein often used for grafting. So during the coronary bypass graft as a RN or LPN, it is very important to nursing care. So we have to monitor the blood pressure, vital sign, and monitor the chest tube. And patient teaching also important. Like treat angina with sublingual nitroglycerin. Tell your patient not to for smoking or consume heart healthy diet. Participate in cardiac rehab program. So it is important educate my patient after coronary artery bypass grafting. In this picture showing this is the narrowing in the artery and then clot formation, and PTCA remove the clot and dilate the narrowing, right, and remove the blocking. So what are the medication we use for coronary artery disease? So, or treatment, nitrate to dilate the coronary artery to decrease the preload and afterload. calcium channel blocker we use for reduce the blood pressure or dilate the coronary artery and reduce the vasoconstriction or spasm. Cholesterol lowering medication to reduce to develop the atherosclerotic plaque like statin, simvastatin, levetiracetam, or beta blocker, atenolol, propranolol, metoprolol to reduce the blood pressure, to reduce or individual who have hypertension. The second disease for the day is called angina, right? So angina, basically, why patient have the angina? If you have a look in this picture, you can see the first picture, the artery is blocking because of plaque, but still the some space is intact or patent and blood is going through, right? But not 100% okay. So angina are developed because of inadequate oxygenation to the heart and causing the pain. Basically, when patient come to you, they said, when I do something, pain start, and when I take rest, pain subside. So relieve the pain with rest, or the pain is disappear after taking nitroglycerin. But nitroglycerin, always it is important, if you should remember, nitroglycerin sublingually tablet, sublingually one tablet every 5 minutes for 3 doses. After 3 doses, if it does not work, you have to call 911, right? So let me read it. Angina is a chronic pain result from myocardial ischemia caused by inadequate myocardial blood or oxygen supply. Angina is caused by an imbalance between oxygen supply and demand. And causes include obstruction of coronary blood flow because of atherosclerosis or coronary artery spasm. So the goal of the treatment for angina to protect the relief of acute attack. Basically, we has to correct the, or we has to make a balance between oxygen demand and oxygen supply. Otherwise, it leads to myocardial infarction. So myocardial infarction occurs because of occlusion of blood flow with necrosis of the vessel, right? So what next? Here showing the type of angina. There are 4 types of angina. One is called variant angina, then stable angina, unstable angina, variant angina, and pre-infarction angina. Stable angina, patient usually complain, when I do work, pain start, and when I take rest, pain disappear. Or when I do something, pain start, and this is called exertional angina. So stable angina occur with exercise, with work. When patient work or exercise. and relief by the rest or nitroglycerin. But unstable angina, it is pain may not relieve with rest. Pain does not relieve even after take the nitroglycerin. So unstable angina occur with exercise or at the rest. An increase in duration or occurrence or severity over that time. What else? Third one is called variant angina. Variant angina, also called Prince metal or vasospastic angina. Vasoseptic. So it is occur because of coronary artery spasm, may occur even at the rest time. So the variant angina related to coronary artery spasm or occur even during the rest. We have to remember it. And last one is called pre-infarction. So just before myocardial infarction, this is the pre-infarction associated with acute coronary insufficiency and last longer than 15 minutes. Symptom of ocean of cardiac ischemia. So what are the different between angina and MI or myocardial infarction? So usually in angina, pain relief after rest or nitroglycerin, but in MI, pain does not relieve. Let me recap it. So pain is unrelieved by rest or nitroglycerin and last more than 30 minutes is indicate of MI, right? So unlike angina, often have other symptoms such as nausea, epigastric discomfort, diaphoresis, and dyspnea, right? So I said in MI, the pain does not relieve even of rest or even take nitroglycerin, and pain is last more than 30 minutes. But angina, most of the times pain subside after rest or pain disappear after nitroglycerin or pain less than 30 minutes. So what are the signs and symptoms of angina? Usually pain, chest pain, and definitely we have to evaluate the nature of pain, radiation of the pain, the consistency of pain, then shortness of breath, dyspnea, pallor because oxygen supply less, sweating or diaphoresis, palpitation and tachycardia, right? So as I told you, when I have chest pain, because of the chest pain, my anxiety increase. When chest pain, anxiety increase, palpitation increase. When palpitation increase, anxiety increase. When anxiety increase, stress increase. Right? It is related each other. Or patient has a history of hypertension. So in case of angina, what are the diagnostic tests for the patient? So diagnostic test we use usually electrocardiography, In case of electrocardiography or electrical graphical presentation, we should get ST segment depressed and T inverted. So here ST segment depressed like coronary artery disease and T wave inversion or inverted, right? It is EKG. And trace test, the chest pain or change in echocardiogram or vascular vital sign during the testing may indicate the ischemia. So you can tell your patient or patient walk over the treadmill and put the EKG, and you can see what are the changes during exertion or walking. So chest pain or change in EKG or vital sign when they walk or ischemic change. Cardiac enzyme or troponin. So what are the cardiac enzyme or troponin change occur here? So usually we can see the findings are the normal in case of angina. But in MI, we can get the huge change in cardiac enzyme like troponin or CKMB, right? Or other marker like, what's it? Myoglobin. So CKMB, myoglobin, or alter monitoring will be changed in case of MI, but all of this normal in angina. So as a nurse, what is our intervention? So immediate management include our following, like monitor the pain, right? Give them oxygen, checking the vital sign. If we see the fluctuating the vital sign, we have to inform the healthcare provider. Also, make sure enough adequate bed rest. Obtaining the 12-lead EKG or electrocardiogram. If we see any kind of fluctuation of events, we have to inform the healthcare provider. Also established an IV access route. We have to open it up. What the other intervention? So assist the client to identify angina precipitating events. So just take a good history, observation, find out what are the underlying cause of pain. Reinforce the instruction to the client to stop activities and rest if the chest pain occur, and to take nitroglycerin as prescribed. We have to make sure. The client is usually instructed to call emergency medical services if nitroglycerin does not relieve the pain. And also, may healthcare provider recommended that the client also take the aspirin. So our function when patient have angina, make sure the nitroglycerin sublingually 1 tablet every 5 minutes for 3 doses. When you prepare the third dose, same time you have to call to the 911 for preparation, right? So we are going to focus right now in the disease called myocardial infarction, shortly called MI, right? So in this picture, you can see the one of the artery is blockage and blood supply is decreased. When blood supply decrease, oxygen decrease as well and lead to some ischemic change or ischemia. And this ischemic change is called infarction, myocardial tissue damage. You see the blackening in this picture. If it is untreated, this infarction increase over the time. So myocardial infarction basically occur of the blood flow if the blood flow reduce or deprived of oxygen. And if the blood flow with necrosis of the vessel within the heart, necrosis occur. And this type of necrosis or pain does not relieve with rest or does not relieve with nitroglycerin. They need something more treatment. So ischemia occurred. First of all, ischemia can lead to necrosis, and infarction does not occur instantly but evolve over hour or time. So if we check some hormonal change or cardiac enzyme will be fluctuate or change, right? So I said, if I ask you, what are the cause of MI or myocardial infarction? You can answer me if they decrease the oxygen supply to the heart. Why oxygen supply? If decrease the blood supply to the heart, right? So usually patient come to hospital with severe chest pain. And in this pain, substernally, just behind the sternum, and the pain is sudden, like crushing pain, and radiate to the jaw or the shoulder and back. So in this picture, you can see the pain radiate to the left jaw, left shoulder, and left arm, and even back. And this pain stay longer than 30 minutes. Keep in mind how to evaluate it from MI. So, or angina, the MI pain is not relieved by rest, not relieved by nitroglycerin, right? And now if you check the enzymatic change, here we can see what lab values will be elevated. If you check the cardiac enzyme, we can see the cardiac enzyme released in bloodstream in response to ischemia in heart muscle. Basically, the CKMB or CPK or troponin increase, right? Like here we said the enzyme, basically when the tissue damage inside the lungs So inside the cardiac muscle, we can see CKMB should be elevated for 2 to 3 days, and troponin T also elevated for 10 to 14 days, and troponin I elevated for 7 to 10 days, and troponin T elevated for 10 to 14 days. And myoglobin, another enzyme, also increase if increase due to the heart damage, or myoglobin also increase if patient has a skeletal muscle damage, elevated for 24 hours. What are the EKG change? What are the most important for us? EKG, they said, women, let me read this page first. Not all clients experience the classical symptom of MI. What are the classical symptoms of MI? Classical symptoms means the sign symptom of the disease. What are the sign and symptom of data collection we have to do? Like patient complain anxiety or palpitation. Just imagine if you have a chest pain. Because of chest pain, you will be undergo the anxiety, and anxiety increase the palpitation more. And all of this will increase your stress out. So anxiety, chest pain, nausea, vomiting, diaphoresis, cold, clammy skin, pallor, or tachycardia. All are the sign and symptom of myocardial infarction, and all lead to the dysarrhythmia or cyanosis, right? After that, say what? Women may experience atypical discomfort, shortness of breath, or fatigue, or often present with non-ST segment elevated MI or T-wave inversion in EKG change. In EKG change, we, in the first picture showing the normal events, right? P-wave, QRS complex, T-wave. But in ST segment elevated means ST segment supposed to be horizontal in the first normal picture. But here showing ST segment elevated. ST segment elevated. ST segment hugely elevated. So ST segment elevated, even some MI patient ST segment depressed, but not normal. What are the normal? It should be horizontal, right? What about the T-wave? So T-wave, like little bit peak or positive deflection upright. But T-wave, you see here, reverse, and this is called T-wave inversion. T-wave inversion, also the EKG findings of myocardial infarction, also we will get abnormal Q wave in this picture, abnormal Q wave. What else? The old client may experience shortness of breath or pulmonary edema, dizziness, altered mental status, and dysarrhythmias. Now go little bit here. According to the location, the infarction also name change. Like here, the heart, this is the atria, this is the right ventricle, this is left atria, left ventricle. Easy way to explain, the right side distributed by right coronary artery and left side distributed mostly by left coronary arteries. So the MI name will be changed because of location of obstruction. If the obstruction on the left coronary artery result in the anterior or septal MI. So like here, if obstruction the circumflex artery is the branches of left coronary arteries. We call posterior wall MI or lateral MI. If the obstruction in the right coronary artery, it is called inferior wall MI. What are the risk factors? So risk factors are atherosclerosis, coronary artery disease, elevated cholesterol level, and smoking, hypertension, diabetic or obesity, physical inactivity, impaired the glucose tolerance or stress. So the risk factor we have to categorize by two ways. Some risk factor is not possible to modify, but some risk factor possible to change or modify, like sex, right? Sex is not possible to modify. So usually the men or male gender is more risk than the female. But after menopause, men and female same under risk to develop MI. Because before menopause, estrogen or progesterone protect the heart. But I'm saying that gender or sex is not possible to modify. It is non-modifying factor, right? Like positive family history. Positive family history is not possible to modify. Means if your father has a heart problem, if your uncle has a heart problem, means you have a positive, strong family history. Genetic cause is not possible to modify. But other factor like hypertension, like smoking, hyperlipidemia, diabetic, stress, inactivity, it is possible to change. If you change your lifestyle, if you change your food habit, if you do exercise, if you avoid inactivity, you can protect your heart, right? So this is the risk factor we should know. And this is the related to the myocardial infection, right? So now let me show and explain this picture where showing the here area of ischemia or obstruction in the artery in the right side, right coronary ischemia start. Obstruction on the left side or left coronary artery, ischemia on the left ventricle. If it is untreated, this small infection covers entire ventricle and causes left ventricular failure. So again, here some diagnostic studies, especially cardiac enzyme. So usually cardiac enzyme release in bloodstream in response to ischemia in heart muscle, like troponin level. Troponin is the most specific to the heart. Then CK. CK stands for creatinine kinase. And more accurately, CKMB. So CKMB more specific to heart than CK. It is elevated for 2 to 3 days. Myoglobin, the myoglobin level raised within 2 hours after cell death. So myoglobin can be elevated due to the heart damage or skeletal muscle damage or rhabdomyolysis. And the myoglobin in case of heart problem elevated for 24 hours. And here, if you do the count, the blood count or WBC, we can see white blood cell count will be elevated. White blood cell. EKG, I want to recap it again. In EKG findings, we can see the EKG show either ST elevated, right, or T-wave inversion, or non-ST elevated means in that case ST segment should be depressed, right, or abnormal Q-wave may be present, right? So in this picture, better showing, in the first it is, you see ST segment is elevated. ST segment is elevated, and T-wave should be inverted T-wave or pathological Q-wave there. Here you see normal EKG, P, Q, RS complex, ST segment is horizontal, T-wave is positive deflection. So ST segment depressed. So ST segment supposed to be horizontal, but in this picture, ST segment is depressed, and in this picture, ST segment is elevated, ST. And T wave should be positively deflect, but here P wave is negative deflection or inverted T wave, right? Is all of this is the findings we found or change would you see on EKG. So what are the diagnostic tests follow the acute states, right? Especially exercise tolerance test or stress test. Stress test may be prescribed to assess for cardiographical change or ischemia and to elevate the medical therapy or identify the client who may need to invasive therapies. Usually 12 lead EKG put it on the patient chest or use the limbs lead and patient walk on the treadmill, and EKG are reflect the change during the exercise. In this picture, already we discussed the sign and symptom of myocardial infarction, right? So nature of pain started from apex beat or fifth intercostal space just below the nipple, but it's radiate to the left jaw, left shoulder, and left arm. Typical distribution of referred pain in case of MI. What are the other sign symptoms? Anxiety, palpitation, tachycardia, diaphoresis, cold, clammy skin, or pallor, right? And common nausea and pain. And here the complication of MI. What are the complication of MI? Because before to go complication of MI, I want to tell you what are the treatment option for MI or medication for MI. The medication for MI, we supposed to give nitroglycerin or analgesia, right? Like morphine, or we have to give oxygen and also analgesic, I like aspirin. And other medication we give beta blocker for high blood pressure, or we can give thrombolytic or antiplatelet medication or anticoagulant. But here it is super important. We have to know, and also we have to know how to easy way to remember. It is called MONA, M-O-N-A. M stands for morphine, O for oxygen, N stands for nitroglycerin, and A stands for aspirin, right? So morphine reduce the pain, and oxygen, we have to apply oxygen via nasal cannula. And nitroglycerin, it is a vasodilator, increase the blood supply. And aspirin, aspirin orally if patient are conscious. And aspirin protect the heart, reduce the pain, and also some anticoagulant properties. Right? So it is the basic um, drug of choice for MI. An easy way to remember MONA, Mona Lisa. So next here, the complication of MI. So acute in the picture, you can see acute myocardial infarction like here. And if it is untreated, there's so many change take place, possible to change take place. In this picture, you can see the stage 1B, stage B, C, and D. So heart disease does not start from one day. First of all, the risk factor. The risk factor, what it is, we discussed already. But if you does not change your lifestyle, if you do not take care of it, this risk factor lead to hypertrophy of left ventricle or diastolic dysfunction. So the left ventricle will be hypertrophied. When wall will be hypertrophy, the room inside will be narrow and there does not enough room or space to collect blood, expel out blood. And always our body try to compensate, and this is called remodeling. But during or when body try to compensate, some change occur. And also another risk factor, atherosclerosis occur and narrowing the artery. If we do not take care of it, lead to cardiac ischemia. And cardiac ischemia lead to MI or myocardial infarction, ischemic change because of less blood supply, and during work increase the demand, but our heart not enough to meet the demand. MI, if untreated, lead to arrhythmias or ventricular dysfunction. In that stage, sometimes patient death, and this is called sudden death. If patient is really lucky, not die, but again your tissue try to adjust, compensate, remodeling, but already some tissue damage. Then ventricle enlargement or hypertrophy again, and finally everything lead to heart failure, again death, right? So all of these basically complication of myocardial infarction. So in a summary, if I said what are the complication of myocardial infarction, one is arrhythmias, and arrhythmia lead to heart failure or cardiogenic shock. If patient have a cardiogenic shock, the symptom sometimes tachycardia, patient develop hypotension, decrease urinary output, or altered the level of consciousness, right? Respiratory or decrease the peripheral pulses or patient develop the chest pain. Other complications are thrombophlebitis, right, or pericarditis, mitral valve insufficiency, or post-infarction angina, or ventricular rupture developed. So all of these are complications of MI. So because of our profession, what is our intervention or nursing care, right? Nursing care is very important. So we have to take care of our patient, make sure patient has enough oxygen supply. We have to monitor vital sign, monitor everyday body weight, regulate input output, position of the patient in high polar, and obtain the chest comfort, discomfort. We have to evaluate it. Admin oxygen by nasal cannula, monitor vital sign, and also assess the respiratory rate and depth to evaluate the heart failure, right? So if patient have the heart failure, we should evaluate by sign symptom or enzyme change or any other laboratory findings. What else? I said patient position is bipolar or semipolar. We have to establish IV access route, 12-lead EKG, or admin thrombolytic therapy as prescribed, or monitor the laboratory values, admin antihypertensive as prescribed like beta blocker, monitor the cardiac dysrhythmia because tachycardia or PVC frequently lead to change, or we give anti-arrhythmic medication, right? So definitely if we have to give the anti-arrhythmic medication, we have to know what are the medication of anti-arrhythmic we used. Like anti-arrhythmic we use for prevention and treatment of cardiac arrhythmia. The major goal of is to restore the function, like diltiazem, digoxin, all of this, verapamil, amlodipine. So monitor the distal peripheral pulses, monitor blood supply. If we see anything abnormal, we have to inform to the healthcare provider. So monitor the bed and make sure patient has to take adequate bed rest. Super important. Also progress to de-angling the legs or progress to ambulation in the client rooms, right? Admin the angiotensin converting enzyme or ECE inhibitor or ARB, angiotensin 2 receptor blocker. Cardiac rehab. Process of activities assist the client with cardiac disease to achieve and maintain vital and productive life, right? Productive life within the limitation of heart disease or coronary artery disease or others. So